Hello, welcome. My name is Dr. Spencer Erickson with P2A Chiropractic, and I'm here. We're going to go over some x-rays again today. Now, I've got a really cool case study today where we're looking at a spinal fusion, a surgical fusion of the lumbar spine. So basically, let me switch it over, and I'm just going to show it to you real quick. I keep doing this wrong. There it is. Okay, so this is the view of it. We're going to be coming back to this in just a second. Now, I have a lot of people ask about fusions for one reason. It's, are you going to hurt me? I have a spinal fusion. Are you going to hurt me? The short answer to that is no. What we have to remember about fusions is once they're fused, they're fused. And so the body, generally speaking, is tough and solid, and it's going to hold together really well. And I usually wait 6 months after surgery is generally very safe. Even 3 months is pretty safe. People are not usually seeking care at chiropractors' offices until long after surgery anyway, and so it's rare that I'm going to put myself or the patient in a position where we're going to be damaging somebody after a fusion surgery. That's the last thing anybody wants. And so we're always very careful. The litmus test I always use is it going to survive a car accident? If the doctor says it's okay for you to drive and potentially get in a car accident, it's more than safe enough to come and get adjusted, especially with as specific as we try to be and as gentle as we try to be, especially when we know about these things. Now, I've actually had patients come in and we learn about different fusions. I literally have had patients come in, we take their x-rays, and they did not know that they had a fusion in their neck or in their lower back. They said, well, my doctor said he did surgery on me, but I don't know what he did. And we go in, sure enough, then they fused. It can be a bony fusion, or it can be a titanium rod fusion. That's what we're going to be looking at today. And so the most important thing really we have to do for patients when they come in here for a general understanding of what's going on in the body is x-raying. This is why I have so many x-rays, and every time I x-ray somebody, I am surprised by something. It's never just, there's no such thing as run-of-the-mill, everyday x-ray stuff. There is stuff that I see quite commonly, but I can't just bank on those things occurring just because they're common. Every person is unique and special, and so they need unique and special care to make sure that we get them fixed to the very best of their potential. Now, let's go ahead and click back onto this x-ray here. So this is a side view. Now I'm going to switch over. This is the posterior to anterior view, or the P2A view. Now we're looking at here, you can obviously see the right and left markers here. So this is the left hip bone, right hip bone. Here's the right ball and socket hip joint. We have a little bit of pixelation down here again. And then we have the left ball and socket joint. You can see there's a little bit of shape difference between the two. This is much more round, and this is a little bit more oblong. But you can see a couple things, like this left hip is up higher, a lot of bowel gas and air bubbles in the stomach and intestines. But like I talked about last time, that's fairly common. Everybody has that stuff. There's nothing wrong with that. So as we're going through here, you can see a couple of big things, and that's these big screws going through here. This is the important thing when we're doing a view like this or looking at x-rays. I have to have two views. If somebody shows me this, I have no idea where those screws are. Well, of course I have an idea, but I need to see exactly what tissues the screws are penetrating through, because there's a lot of front to back tissue in there. And so I need to make sure that it is exactly where we're looking. And so what we do is we take a lateral view. Now there are a few things to notice on here. You can actually see the screws. If I zoom in on that, you can see the ridges of the threads of the screws. Now as we're going through here, what we're going to count is we're going to count L1, 2, 3, L4, and L5. So of course this is the L5 disc is what we were counting. So this is the L5 vertebra, and here's the tailbone of the sacrum. Now, what you can see if you look at the back margin of this, I'm going to zoom in a little bit here. Here's the back corner of L5. Let me put a dot on there. Dot, and then here's the back corner of the sacrum. When this individual went in for surgery, he had a very traumatic incident. This is actually a helicopter pilot in the Army who had 2 crashes, and one of those crashes caused this to happen. And so what happened, he came down really hard, broke the bone back here that locks L5 on the tailbone. It's called the pars interarticularis, and broke one or both of those, and L5 literally just slid forward. That's why the back corner of it's here instead of lined up back here, right above the back corner of the tailbone. So this is called the spondylolisthesis, and it's on top of that, it's called a traumatic spondylolisthesis. And so this is a pretty severe injury. If somebody comes in and their back is fractured like this, this can do damage to the nerves and a bunch of other tissue in there. And so we need to be sure that this gets treated accordingly and appropriately. So a fusion for this kind of thing is definitely an appropriate way to go, rather than losing neurologic function and cutting nerves and all that kind of stuff, which can happen with these things. Now, one thing I want you to notice here, I'm going to zoom back out a little bit. It's a little bit easier frame of reference when you're backed out a little bit. If you look in between these bones, do you see these gaps? Now, in between all the gap, or in between the bones, that's where the discs live. So we call them disc spaces. We can't really see disc tissue on X-ray. So don't let people tell you can see discs on X-ray, because you can't. You can see them on MRI or a CT, but you can't see them on X-ray. But these are all great big spaces here, and they all look really nice and young and healthy. This one, however, does not look really nice or young or healthy. This has been really smashed. So there's a lot of trauma involved with this. Now, what we also have to realize is this fusion was done 15 years ago, or 15 years prior to when these X-rays were taken. And so if that's the case, then we're going to have a significant amount of wear and tear and damage in the discs. If you isolate a disc like that, it will break down. It'll start breaking down within a couple weeks. And over time, it just gets smaller and smaller until it's just completely non-existent. Now, we have a couple metal artifacts, it looks like, in here. I don't know if they tried a disc replacement at some point, because this is actually a second surgery. The first surgery failed, which is very common for low back surgeries. And so they had to actually go in again and do a surgery again, which is very unfortunate, because the recovery time for these things is not fun, and it's not short. But they were able to stabilize them a little bit better. Now, the also unfortunate thing is he's continuing to have pain. That's why he came to see me, of course. But if you have persistent pain after the back surgery, it's basically just failed back syndrome, which is really unfortunate, because the last thing they want to do is go in and risk further risk of infection and risk further injury by going through and redoing a back surgery like this for a third time. And so he basically had a failed back syndrome, which is a real thing, and it's a common thing. Now, one thing I want to point out is look at the screw head here, or the tip of the screw rather. It's actually pierced through all the way through the bone tissue, and so it's sticking out into the soft tissue here. This could actually be a pain generator too. But yeah, I'm not here to be critical of the surgeon, but hardware is hardware, and so we have to be aware of what's going on in there. So what I'm doing when I adjust this guy is I'm basically moving L4 and L3. Now, the importance of L4 is that when you take and fuse one of these discs here, it's going to transfer whatever load this disc was bearing onto the next disc up. Now, that's, of course, going to push a little bit of its load on the next disc up and so on. But this disc is going to get really heavily overloaded once this disc is completely out of play. What they've done with the surgical fusion here is they've taken these bones and basically welded them together effectively. And so this is the same bone now as this, if you look at it biomechanically. And so when we're looking at this one here, yeah, this disc is actually still in pretty good shape, which is really good, and we can keep that nice and healthy. What we have to do with this is we have to mitigate, and we have to maintain this disc as much as possible. So regardless of pain levels, even if this guy's not hurting at all, he needs to get adjusted periodically, or else this disc is going to get overworked and it's going to wear out prematurely. And then eventually he's going to have a fusion here. A lot of patients will come in after fusions and say, yeah, my doc told me that the next disc up, he wants to see me every 5 years or so, 3 to 5 years, to make sure that this disc isn't wearing too fast, because he says eventually we're going to have to fuse that. And so my goal when people come in here like this is that we never have to fuse this, that we just keep maintaining the function in there as long as possible. Now, what else do we want to talk about? I think that may just sum everything up, may wrap everything up. If you have questions on fusions like this, spondylolisthesis, traumatic spondylolisthesis, or that kind of stuff, let me know. Like I said, the very best thing to do most of the time when people have questions, they've never had X-rays before. And so what we do is we just take X-rays. It takes like 4 minutes. We can do X-rays really fast. They're not terribly expensive. In fact, they're really, really inexpensive, especially for the amount of information that we get from them. But I can identify on X-ray so many important things, areas that are wearing out in the spine, areas that have bone spurs or disc degeneration, fusions. There are lots of different things that we can see on X-ray. And so they're one of the most valuable tools that I have for diagnosis. Because if I can find that area and work that thing out, it's eventually going to get to a point where it's going to maintain itself forever is the goal. And so what we want to do is we want to free you free patients who come in here from the stress that comes along with all of this stuff that we're talking about. So anyway, if you have questions, let me know. It was fun to sit down and go through this today. I've got another one that I'm going to go through. The one that I'm thinking of is a little gal that has Harrington rods. Those are actually rods they put in the spine to strengthen a big scoliosis. And so maybe we'll go through that one next time, or sometime coming up. If you have specific questions or things that you'd like to see on X-ray, and you think maybe I have an example of that, then let me know. Spina bifida occulta comes to mind. There are lots of different anomalies that can happen, and so I will look at working some of those things in as well. But if you have special requests, let me know. If you have questions on anything, let me know. Now, contact is very easy. The office number is 801-762-6940. You can also email the front desk at timpyreception@gmail.com, or you can email me, drspencererickson@gmail.com. Let's see, or facebook.com/timpychiropractic. I don't get great notifications on that, but I do check it. I do try to check it fairly often. Anyway, hope you enjoyed today. If you have any questions, let me know, and we'll talk to you soon. Thanks.